Hi, I'm Ryan Beatty,
And I'm Nick Kling.
and our DMP project is on ultrasound guided gastric volume assessment for student nurse anesthetists.
Our learning objectives are to discuss perioperative aspiration, complications, and risk factors, to improve confidence and knowledge in recognizing the steps, landmarks, and appropriate situations that call for ultrasound guided gastric volume assessment, to improve confidence in provider technique and ability to perform ultrasound guided gastric volume assessment, and a demonstration of an ultrasound guided gastric volume assessment.
Pulmonary aspiration is defined as active or passive regurgitation of gastric contents into the trachea and lungs due to abolished laryngeal protective reflexes. Although the risk of perioperative aspiration of gastric content is low, it remains one of the most feared complications associated with anesthesia. The documented incidence of perioperative pulmonary aspiration varies in the literature due to lack of valid detection markers that make it difficult to identify, but several retrospective and prospective studies have been conducted and they report an incidence of 1 in every 2 to 3,000 cases. While the incidence of known aspiration events is low during anesthesia, the rate of silent regurgitation with possible aspiration may be much higher. In a review by Smith and Ng from 2003, researchers found that when intraesophageal pH electrodes were used to identify acid reflux, it occurred in up to 16% of elective surgical cases, 47% of gynecologic laparotomies, and 28% of thoracic surgeries. This is clearly a much higher rate than is predicted by the other retrospective studies.
Pulmonary aspiration of gastric content can have many serious consequences that result in significant morbidity and mortality. A study conducted by Perlis and colleagues reported the risk of morbidity and mortality to be 8 to 10% in patients that require long-term mechanical ventilation as a result of aspiration pneumonia. The most common complications associated with gastric content aspiration is pneumonitis, which is direct injury to the lung parenchyma. The presence of low pH, high volume, and presence particulate place the patient at the highest risk for aspiration pneumonitis. Perioperative aspiration also poses a financial burden for both patients and healthcare institutions, as the average cost associated with aspiration pneumonia is estimated to be around $16,000 to $30,000.
One of the most important risk factors for aspiration is large gastric volumes, which is primarily determined by gastric emptying. Gastric emptying can be altered in patients that are diabetic, pregnant, obese, in pain, on opioids, and those with a bowel obstruction, hiatal hernia, or gastroesophageal reflux disease. Providers rely on the presence of these risk factors to predict delayed gastric emptying and guide practice, but these are not always accurate or available. Darwich and colleagues from 2003 state that up to 50% of diabetic patients have altered gastric emptying, but the predictive value of clinical symptoms is low as the delay is mild and in most cases can even be accelerated. Morbidly obese patients are believed to have delayed gastric emptying, but recent studies show that they usually have normal preoperative gastric volumes. These unpredictable gastric emptying risk factors highlight the need for a tool to objectively measure the amount of gastric volume. In order to prevent patients showing up for surgery with full stomachs, the American Society of Anesthesiologists, ASA, has put forth strict fasting guidelines that recommend patients to stop consuming clear liquids 2 hours before surgery and solid food 6 hours before surgery for a light meal and 8 hours for a full meal. However, these fasting guidelines offer no information on the patient's actual gastric content at the time of surgery and cannot be relied upon in many circumstances, such as emergent surgeries, patients with unpredictable gastric emptying, and patients that lack understanding or neglect to follow the recommendations. Another factor that must be taken into consideration is the critical threshold of gastric volume that puts patients at risk for aspiration. While some studies conducted on primates suggest that the volume of 0.8 milliliters per kilogram is linked to greater aspiration risk, the vast majority of studies identify the critical threshold to be 1.5 milliliters per kilogram of gastric volume.
The gastric wall is 4 to 6 millimeters thick and has a characteristic appearance of 5 distinct sonographic layers that are best visualized with a high-frequency transducer. These layers help differentiate the stomach from other hollow viscera. The layers consist of the serosa, which appears thin and hyperechoic, the muscularis propriae, which is the most prominent layer and appears hypoechoic, the submucosa, which appears hyperechoic, the muscularis mucosa, which is hypoechoic, and the serosa, which appears as a thin, hyperechoic region. The region of the stomach that is most amenable to sonographic examination is the antrum, and evaluating this area with the ultrasound has been shown to accurately reflect the content of the entire stomach. Other landmarks that should be easily identified with ultrasonography include the left lobe of the liver, the pancreas, the aorta, and the superior mesenteric artery.
Distal parts of the stomach, such as the antrum, are better evaluated in a supine, semi-sitting, or right lateral decubitus position, as a greater portion of the gastric content will move towards the more dependent parts of the stomach in these positions. Ultrasound examinations should begin with the supine position followed by the right lateral decubitus. It is important to note that you should never assume the stomach is empty solely based on assessment in the supine position, and the antrum should always be assessed in both positions to accurately identify gastric content.
A curved array, low-frequency transducer is most useful in adults as it provides the necessary penetration to identify the anatomical landmarks. A linear, high-frequency transducer can be used in more lean patients as well as pediatric patients. When scanning the antrum, it is important to hold the ultrasound so the scanning area is parallel to the arm. To start, apply lubrication on the skin and place the probe in the epigastric region between the xiphoid process and umbilicus. This will provide a view of the antrum in the sagittal plane. Once the probe is in the correct location, sweep the transducer left to right in the subcostal margins to identify landmarks.
In an empty stomach, the gastric antrum appears flat with anterior and posterior walls juxtaposed to one another, creating a bullseye appearance. The antrum is round to ovoid in shape in either the supine or right lateral position, and the tissue layers of the gastric wall are best visualized in a fasting state.
Baseline gastric secretions, water, tea, and black coffee appear hypoechoic or anechoic. After ingesting clear liquids, the antrum becomes round and distended, with clearly visible hypoechoic fluid, producing thinning of the gastric wall and a starry night appearance. Typically, the antrum appears larger when subjects moved from supine to right lateral decubitus position as the fluid moves towards the more dependent areas of the stomach.
Immediately after ingesting a solid meal, a typical frosted glass appearance can be seen. This is caused by air mixing with the food during the process of chewing and swallowing. The air and solid mix creates artifacts which can blur the antrum walls, making it difficult to perform a precise quantitative assessment. Because the gastric content is semi-solid, the appearance of the antrum does not vary significantly between supine and right lateral decubitus position.
A semi-quantitative three-point grading system can be used as a simple screening tool to differentiate low from high volume states. This grading system is only used for clear liquid-containing antrums and requires scanning the patient in both supine and right lateral decubitus positions. Grade 0 is when the antrum appears flattened and empty in both supine and right lateral positions. These findings suggest that no gastric content is present and the patient is at low risk for aspiration. When fluid or food is seen on the ultrasound with the patient in the right lateral decubitus position, but appears empty when the patient changes to supine position, this is classified as grade 1. In 75% of these cases, the subjects will have less than 100 milliliters of gastric volume and are considered low risk for aspiration. Grade 2 classification is when fluid or solid food is identified on the ultrasound in both the right lateral decubitus position and supine position. In 75% of these cases, subjects have over 100 milliliters of gastric fluid and are considered to be high risk for aspiration. The vast majority of fasted individuals, around 95%, present with grade 0 or grade 1 antrum assessments, which correlates with low gastric volume and therefore low risk of aspiration.
Common scenarios where ultrasound-guided gastric volume assessment should be utilized include patients that have not fasted, have delayed gastric emptying, or provide an unreliable history. Patients may present for surgery without fasting for many reasons. They may lack the understanding or simply neglect to follow the fasting guidelines. Other reasons include urgent or emergent surgeries where the patient is rushed to the OR without adequately fasting. Patients with delayed gastric emptying present a unique challenge as they may have followed the recommended guidelines but still have elevated gastric volumes. Anesthesia providers are trained to identify patients that may have delayed gastric emptying based on risk factors such as diabetes, obesity, pain, or pregnancy. However, these risk factors are unpredictable and don't offer any information on the patient's actual gastric content. Utilizing gastric ultrasonography will provide the objective information needed to guide care. Ultrasound-guided gastric volume assessment may also be used in any patient with an unreliable history, such as those with a language barrier, cognitive dysfunction, or altered mental status.
Now we will demonstrate an ultrasound-guided gastric volume assessment on a live model in both fasted and non-fasted states.
Step 1. Ensure the patient is in the supine position.
Step 2. Place the ultrasound machine equipped with a 2 to 5 MHz curved array transducer next to the patient.
Step 3. Apply lubrication to the skin and place the probe in the epigastric area between the xiphoid process and umbilicus.
Step 4. Hold the ultrasound probe so the scanning area is parallel to your arm.
Step 5. Sweep the transducer left to right in the subcostal margins until the landmarks are located.
Now you will locate a cross-sectional view of the antrum, the liver, the superior mesenteric artery, and the aorta.
Step 7. Assess the size and appearance of the antrum. As you can see, the antrum appears small and non-distended and has a bullseye appearance in the fasted patient.
Now have the patient shift to the right lateral decubitus position.
Step 9. Same as before, place the ultrasound probe in the epigastric area between the xiphoid process and the umbilicus.
Now sweep the transducer left to right in the subcostal margins until landmarks are located.
Locate the cross-sectional view of the antrum, liver, superior mesenteric artery, and aorta.
Assess the size of the antrum. As before, the antrum appears small, non-distended, and has the bullseye appearance.
This ultrasound-guided gastric volume assessment has demonstrated that the patient has minimal volume in his stomach and is a low risk for perioperative aspiration. Now we'll perform an ultrasound-guided assessment on a patient after drinking 32 ounces of a clear liquid beverage.
Step 1. Ensure that the patient is in the supine position.
Step 2. Place the ultrasound machine equipped with a 2 to 5 MHz curved array transducer next to the patient.
Step 3. Apply lubrication to the skin and place the probe in the epigastric area between the xiphoid process and the umbilicus.
Step 4. Hold the ultrasound probe so the scanning area is parallel to your arm.
Step 5. Sweep the transducer left to right in the subcostal margins until the landmarks are located.
Now you will locate a cross-sectional view of the antrum, liver, superior mesenteric artery, and aorta.
Step 7. Assess the size and appearance of the antrum. As you can see, the antrum in this patient is distended and has a starry night appearance.
Step 8. Now have the patient shift to the right lateral decubitus position.
Step 9. Same as before, place the ultrasound probe in the epigastric area between the xiphoid process and the umbilicus.
Step 10. Now sweep the transducer left to right in the subcostal margins until the landmarks are located.
Step 11. Locate the cross-sectional view of the antrum, the liver, the superior mesenteric artery, and the aorta.
Step 12. Assess the size and appearance of the antrum. As before, the antrum appears large, distended, and has a starry night appearance.
This ultrasound-guided gastric volume assessment has demonstrated that the patient has a large amount of gastric content and is high risk for perioperative aspiration.